can hear me. So we'll talk about strokes today. If there's time, we'll talk about Guillain-Barré. It's quite a short topic. So let's look at stroke. Okay. Before we go on, hope time would permit us to do this, but let me see if I can get a case study for you. Okay, can you see my new screen?
Yes, sir. Yes, sir.
It's a Word document. I don't know if you can see it.
Yes, sir.
All right, great. They have a 52-year-old.
Yes, sir.
Okay. Okay, so let's quickly touch on this.
Yes, sir.
So you have a 52-year-old banker who was rushed to the ER, and this patient was rushed in because of sudden collapse. So he's a known hypertensive, and basically he had defaulted treatment for the past 4 months. The people who brought him said that he was well, he was in his usual state of health until some hours prior to presentation when he started complaining of severe headaches. So when they brought him to you, the blood pressures were high. You had about 190/120. The pulse rate was about 126 beats per minute. Your SpO2 was about 91% on room air. And your random blood sugar was 10.7. So they brought this patient, and then, of course, you started your initial assessment and then your emergency management ABCs. So upon regaining consciousness, you noticed that the patient had developed a right-sided hemiplegia, and the patient was also aphasic. Okay. Right-sided hemiplegia with aphasia, and you tested the patient's reflexes. Initially, the reflexes were absent, but later on, the reflexes became increased with what we call an extensor plantar reflex, okay, sign being present, or Babinski sign being positive. You requested for a HCT scan to be done for the patient. The patient did the head CT scan, and then you found a hypodense lesion in the left frontal parietal aspect of the brain. So as a clinician, you've seen this case, you've seen the vitals, you've asked that they do a head CT scan. They brought the head CT scan report to you. What would you make of this? Let's have a discussion. I mean, this is also part of the lecture, so let's have a discussion. If you see this in your setting, what would you think of this case? I mean, let's look at the patient here. Can anyone tell us the patient's issues? That is how you attack this question. So what are the patient's issues? Anyone? I have names here so I can mention to see if we are really in class. If you are not talking, kindly mute your mics. Okay, if you are not talking, please mute your mics. If your mic is on, then it means you want to talk. If we mention your name, you unmute and then you talk. So looking at the case study presented here, let me give you guys 3 minutes to read through. Maybe you haven't really read through, so 3 minutes to read through and put down the problems this patient has and let's discuss it. And then we can move on to our lecture. I think we've all gone through, so let me get your inputs. What are the man's main issues? That's, the first thing we need to look at. And then based on that, we can make a diagnosis.
Yeah, hello, Doc.
Yes, please.
Yeah, I'm thinking the man is having emergency hypertension.
Okay.
And she's also having a respiratory distress.
Okay. Okay, and what else?
Hello, Doc.
Yes, please. Hi.
So the problem, he's a known hypertensive and he has defaulted. And then
Okay.
before he collapsed, he complained of severe headache. And then after he regained consciousness, he has right-sided hemiplegia. So I think he suffered a CVA.
Okay.
Yes.
Okay.
And well, the BP, because it's a known hypertensive, the BP probably shot up, and he didn't know because he doesn't check, and he's not taking his blood. So that is when the BP shot up, and he had severe headache as a result of the BP going so high, and then he passed out as a result of it. And the right-sided hemiplegia is an indication that he suffered a CVA. That's what I think.
Okay. All right, great. Okay, so that's good analysis there. Thank you very much. So yes, when you look at this case, there's a non-hypertensive, and ideally if he's taking his medications, you don't expect the blood pressure to rise so high. That's one. We can also see, as the first speaker said, the saturations are dropping over there, as you can see. Pulse rate is also going up, so there's some sort of distressing situation going on here. And when you look at the question critically, as Rabi said, you have some form of hemiplegia there, which actually would point to something neurological. Okay, so looking at the blood pressures, looking at this neurological complication of the elevated blood pressures, clearly that tells you that we are dealing with a CVA. Okay, so when you look at this question, you would say, okay, based on the patient's problems and the history prior to the sudden collapse, and now the hemiplegia we have, and even when you go on further, you see more clues there, an extensor plantar reflex, which tells you that they are dealing with an upper motor neuron lesion, which will be we'll see what that is in a bit. I expect that clinical methods to touch you, but we'll still go over anyways. So with that, and then the fact that they even went ahead to do a CT scan, the CT scan said they found a hypodense lesion. Now, this is the catch. If you should get this in an exam, and then the first question is, what is the likely diagnosis? And you tell me that it's a CVA. You are right. But then you don't stop there, because looking at this, they've gone ahead to do a head CT scan to define the type of CVA that we have. And in this case, they said hypodense lesion. So as we go on, we will know what a hypodense lesion means, and then a hyperdense lesion means. And of course, once you make a diagnosis of CVA, you should also be thinking of other things. And that's where differential diagnosis comes in, because it's possible that a CVA per the history and whatnot. But then, what if it's not a CVA? What else could it be? Right? What else can also give you some sort of focal neurological deficits? So you should know things like that. You should know the risk factors that would bring up a condition of this sort. Apart from a head CT scan, you should know the other investigations that you need to do to help make your diagnosis. All right. And then, of course, you should know how to manage your patient. Okay. So we'll go to our lecture, and then hopefully at the end of the lecture, you should be able to answer this question. So your seniors wrote an exam on Friday, emergency medicine, and this was the question 1 of the emergency medicine. It might pop up somewhere else, you never know. All right, so CVA and strokes. So let's do a quick anatomy for those of us who have forgotten how the brain looks like or what the brain entails. So this is a sagittal section of the brain. It's been split into two halves or two hemispheres. So this is just one hemisphere. And you know that the brain has a different aspect. So you have the frontal, you have the parietal lobe, you have the temporal lobe, and then you have the occipital lobe, right? So I mean, that's the frontal, then the parietal, then if you should look at the green aspects going to the side, that's the temporal, and then that becomes your occipital lobe. Okay, and then so this whole thing here is the cerebrum. Okay, then lying under the cerebrum, you have the cerebellum, which you can see here, right? Then you have from here what we call the brain stem. The brain stem is made up of the midbrain, the pons, and then the medulla. These things are not just there for jokes, so I'm not just saying them for jokes, because whatever we are going to do now, we will be mentioning this word, so you should try and remind yourselves or familiarize yourselves if you've forgotten. Of course, if we are talking about strokes, we are going to know what a stroke is. For instance, a patient who has a stroke, and this stroke is here, this aspect, the frontal lobe here, okay, would exhibit different features, clinical features from a patient who has a stroke in the brainstem. And that's why you should know the parts, so that when you see the features, you can tell that, oh, okay, this stroke is actually in the cerebrum, or this stroke is actually in the cerebellum, or this stroke is in the brainstem. Okay, so that's why you should know the parts. So if we talk about the stroke, you hear people saying stroke. What does it mean? Okay, then this definition is essential that you should know, because there's a time frame attached to it, and then they are also specific in saying that whatever happens, whatever damage that is happening is arising from a vascular source. Okay, so we are saying that stroke is a syndrome, and this syndrome will basically cause a rapid onset of cerebral deficit. Okay, so there's a rapid onset of deficit of any part of the brain. Okay, and this deficit will usually be a focal one, or a focal neurological deficit. And whatever is causing this deficit should be due to a vascular problem. That is what makes a stroke. Okay, so if you have a patient who comes to you and has left-sided weakness, right? You have a differential in your head, or you are thinking of a differential that, all right, okay, this could be a stroke with left hemiplegia. At the same time, you're also thinking this could be something else. Maybe this could be a tumor sitting there in the right hemisphere, which is causing left-sided weakness. You would only know after you've done your CTs and it confirms that, all right, whatever is happening is of a vascular source, and so you have a stroke. Okay, so if you have a problem high up in the brain, and this is causing a neurological deficit, and it's not a vascular one, then you can call this a stroke. The cause of the cerebral deficit should be a vascular one. And usually for you to be able to stick out your neck and say this is a stroke, you would need to wait for at least 24 hours. Okay, because sometimes you would have patients who come to you with focal neurological deficits. This would last for, less than 24 hours, and the patient will recover. You won't call this a stroke. You rather call this a transient ischemic attack. If it's also of a vascular origin, you would call this a TIA. Okay, so it's very, very, very essential that we keep those timelines up there, right? So what is happening is that this patient has an issue, which is a vascular one, and that can either mean that there's poor blood flow going to an area of the brain, which could be due to the fact that the blood vessel supplying that area has been blocked, that is one, or the blood vessel supplying that area has ruptured, that is two. Okay, so you have a vascular problem, and the problem could be either due to blockage of vessels in the brain, or a rupture of vessels in the brain. And this blockage or rupture is basically leading to a neurological deficit, and this deficit should last for more than 24 hours. We're saying if the deficit fails to last for more than 24 hours and the patient recovers, most of the time, it's just what we call a transient ischemic attack. And once we go on, you'll know what a transient ischemic attack is. So when people start developing this focal neurological deficit, it would usually go through phases. So if you've seen a patient who has a stroke before, if they rush the patient to you, I'm talking about an acute stroke. they rush the patient to you and the stroke is now setting in, you won't have a classic feature there for you to say that, oh, this patient has permanent weakness on the left side, or this patient has this. They would come and then the features would usually evolve. So the patient will come and say, oh, maybe initially I felt my face being numb, and now I'm feeling one side of my body going numb. So they will come with symptoms or features that are evolving, okay? And usually once they come with that, you would say that, all right, okay, so this is a stroke in evolution, okay? It means that the stroke basically is now starting. It's not a fully established stroke. It's in the process. It's undergoing changes until eventually you end up having what we call a completed stroke, okay? Thing is that most often, a stroke in evolution would basically within 6 hours would lead to a completed stroke. Most of the time, once you have it evolving and all that, within 6 hours, you're going to have a completed stroke. Okay, but looking at the term stroke in evolution itself, we say that it describes stroke progression within the first 24 hours. So sometimes it won't just settle as a completed stroke within 6 hours. Sometimes it will go beyond that. But then all the changes that it goes through within the first 24 hours, all the changes in clinical features or neurological features will be seen within the first 24 hours in a patient who has a stroke. We'll term it as stroke in evolution. If the patient the evolution comes to a halt, we say this is a completed stroke, and most of the time, this is within 6 hours. Some patients would also develop a stroke, okay? And in this case, if I talk about stroke, I am talking about a neurological deficit, which is due to either a blockage of the blood vessel to some part of the brain or a rupture of blood vessel to some part of the brain. So a patient will develop a stroke, and this stroke would usually sort of resolve within a week, okay, without any significant deficit at all. And that is when we say, well, the patient has had a minor stroke. So you know that most of the time people say, oh, he's had a minor stroke before. That is what it means. It means the person had a stroke, and I mean, within 1 week, it was fine. No symptoms at all. If he doesn't tell you, or she doesn't tell you she's had a stroke before, you never know. Okay, so this patient, usually there'll be a focal neurological deficit, which will progress for more than 24 hours. So you can actually apply the term stroke to it. But then within a week, this patient is fine and be walking around normal. Then there's transient ischemic attack, where basically there's a focal neurological deficit, but it's just for a very brief moment. Maximum less than 24 hours, patient to be fine. Okay, so we've had patients who come to us and they are fine, they are walking okay, but then we tell you that all of a sudden they can't see in one eye, or all of a sudden they can't talk, okay? But you examine the motor in the upper and lower limbs is fine, right? And then you say, all right, okay, let's observe and see. And in less than 24 hours, this patient start talking or is able to see. What the patient had is a transient ischemic attack. And transient ischemic attacks are just warnings. It tells you that, hey, today you've had a field day, you're lucky, but next time when I come, I'm coming to stay. So you have to check your life. That's what a transient ischemic attack is. All right. So etiology, what would usually cause a stroke? And we are looking, as I said, we are looking at it in two ways. Either there's something blocking the blood vessel, or there's something causing a rupture of the blood vessel, okay? So you can have an emboly. An emboly is like a thrombus, which is in circulation. You know, a thrombus in the layman terms is a blood clot. So you can have a blood clot in circulation. Probably there you have like some blood clots formed in the heart, and then maybe you have a patient who has atrial fibrillation. So that's a classic example. So atrial fibrillation, we know that because the heart is beating so fast, then basically the atrium doesn't even allow the ventricles to fill. it's beating so fast, but then it's not even beating with that much strength. So you have pooling of blood in your atrium. And once you have pooling, you remember the Berkhoff's triad, you can end up forming a blood clot. And once you form this blood clot in the heart, it can dislodge and then go through the aorta and end up in the brain. And then you can have a stroke from there. You can sometimes also have a blockage in the blood vessels of the brain itself. Your cerebral arteries can become clogged or something, and then you can have a stroke. Sometimes the blood pressures can go so high that it can lead to rupture of the blood vessel, what we call intracranial hemorrhage, which will lead to a stroke. You could also have a vein becoming blocked, and this will lead to poor perfusion of some aspect of the brain. You are going to have what we call a venous infarction. Then you can also have what we call a carotid or vertebral artery dissection. Okay, if you remember aortic dissection, you can have a blood vessel, and then the inner aspect of the blood vessel, what we call the intima, the inner aspect can actually rupture, but then the outer aspect of the blood vessel looks fine. And because of this ruptured inner aspect, blood will start seeping through the ruptured inner aspect, and it would sort of enter the muscular layer through to the outer layer of the blood vessel. So you realize that pressures in the vessel would be dropping, but then the patient wouldn't be bleeding out. The issue here is that the rupture of the blood vessel is not outside. The rupture is inside the blood vessel itself. So the patient is going to leak blood through into the muscular layer of the blood vessel. That's what we call a dissection. So you can have a carotid dissection. You all know the carotid artery, the internal carotid artery and its branches, and goes all the way up to the brain, or a vertebral artery dissection, which also goes to the brain. So once you have a dissection here, you're in trouble. Sometimes you can have excess red blood cells, or you can have conditions that will make your blood a little bit viscous. And once you have hyperviscosity, there's poor supply to tissues. You can also have fat or air in circulation, and that can actually lead to a stroke. One of the reasons why we always say that when you are going to give your patients medication, try and expel all the air out of the syringe is because of air embolism. Because if you don't take care, you are going to introduce air, which can end up causing a stroke. Risk factors. So from the case study, we saw the man is hypertensive. Also, if you're diabetic, you have high cholesterol levels, you are obese, you drink, you smoke. If you have conditions like carotid artery stenosis, if you have sleep apnea, if you have thrombocythemia, which means excess platelets, if you have infection or inflammation of the inner aspect of the heart, endocarditis, if you have a vasculitis, increased homocysteine levels, conditions like neurosyphilis, drugs like cocaine, COX-2 inhibitors, and conditions like amyloidosis, all of these things can have an effect on the vascular system, and then it can lead to poor perfusion to the brain, which of course will lead to a stroke. So ideally, the body functions in such a way that even when your blood pressures go up to a certain limit or falls below a certain limit, it doesn't affect perfusion to the brain. The brain has a constant perfusion pressure. So there's something we call the cerebral blood flow. So this cerebral blood flow is basically independent of perfusion pressure. So the cerebral blood flow is ideally maintained at a mean arterial blood pressure of 60 to 120 millimeters per mercury. And this principle of maintaining cerebral blood flow within 60 to 120 is called autoregulation. Okay, so if your BPs go up or it goes below certain limits, it doesn't really affect your cerebral blood flow, because once your brain, as we all know, once perfusion to the brain becomes impaired, then you're going to have issues. So every now and then, the pressure there is maintained at a constant pace just to keep things going. This principle is called autoregulation. However, you could develop some conditions which would impair autoregulation. So if you, by any means or by any chance go into shock where your systolic blood pressure starts falling below 75, okay? Or your BP goes so high, like the case study we saw, where systolic blood pressure was above 180. These two things would actually affect the principle of autoregulation. And once the principle of autoregulation is affected, it's actually going to lead to poor perfusion of blood flow, either due to probably a rupture or maybe a blockade. But in the end, it will just lead to poor perfusion of blood flow. And that is what matters in a stroke. There's a poor perfusion to the various aspects of the brain. So those are the two things. Also, when intracranial pressure goes up, and we know that in severe hypertension, you can have raised intracranial pressure. That can also affect cerebral blood flow autoregulation. When the blood flow becomes highly viscous, that could also affect cerebral blood flow autoregulation. When the partial pressures of oxygen falls or the partial pressures of carbon dioxide goes up, you are actually going to have impairment of the cerebral blood flow autoregulation. So these 5 things would impair the principle of autoregulation. And once autoregulation fails, then it means that you are going to have a poor perfusion to various aspects of the brain. In terms of clinical syndromes, we have 3 main syndromes. We have transient ischemic attack. We have infarction, which is basically due to a blockage. So of course, once there's a blockage, there's poor perfusion to the distal part of the vessel. And then you have hemorrhage, which is the other one, which means that the vessel has ruptured. Okay, so these are the 3 main clinical syndromes when we want to talk about a cerebrovascular disease or a stroke. The first one, which is a transient ischemic attack, is not classified as a stroke, as I said, because it's less than 24 hours, but you should know it because it's a warning sign. Let's look at investigations that we do for stroke. So we go ahead and do a head CT scan, which is very essential. It tells us the type of condition we have. If you have a transient ischemic attack, the head CT scan will come and then it would be basically normal. Okay, but if you have probably an infarctive stroke, it will come and then it will show you a hypodense area. If you have a hemorrhagic stroke, it will show you a hyperdense area. Okay, we'll see pictures in a bit. Of course, you need to do a full blood count, ESR, lipid profile, clotting profile, chest X-ray, ECG is very essential. You would want to know the patient's the cause of the stroke. So your chest X-ray can tell you if probably the heart is breaking, if there's cardiomegaly, if the patient has some other condition, maybe a congestive cardiac failure. Your ECG would also tell you probably the patient has some form of atrial fibrillation, which is what is causing the stroke. The carotid artery Doppler, as we know, when the carotid artery becomes blocked or you have arteriomatous plaque sitting there, which is one of the main causes of a stroke and infarctions, once you do a Doppler, it tells you that, oh, there's a clot in the internal carotid, and actually that is what is causing the poor perfusion to the brain. So that way you just need to just manage and get the clot out or the arteriomatous plaque out. And also an MRI angiography would help you see the blood vessels involved. So there's a picture of a CT scan, 2 CT scans. So you can see the infarctive stroke shows this area looks darker. So this is a hypodense area, right? And then hemorrhagic stroke, you can see that this area looks whiter. So this means that the blood vessel has actually ruptured. Patient is bleeding. If a patient is bleeding and you take a head CT scan, this is what you should see. It should look white. And if the blood vessel is blocked and you take a head CT scan, this is what you should see, dark. Okay. When you go for your clinicals and you have a stroke patient, be eager to look at the head CT scans. If you look, usually with infarctive strokes, you have to look more before you can see the dark part. The hemorrhagic stroke, as soon as you take it, you will see something of this sort. Okay. Mind you, it's not always that when you see this, it means there's a bleed. If a patient has a tumor and they did a CT scan with contrast, the tumor might also look like this. So history is also very, very essential. Okay. So let's look at a transient ischemic attack. So as I said, there's a neurological deficit. This will just last for less than 24 hours. Clinical features, you can have a sudden loss of vision in one eye. We call it amaurosis fulgus. Sometimes you can just have one-sided weakness, what we call hemiparesis. Sometimes we've had patients who were fine and just the next day they couldn't talk. Okay, it's called aphasia, and they usually recover in less than 24 hours. Sometimes you just forget every single thing, okay, for less than 24 hours. It's called transient global amnesia. Okay, other features include diplopia, means you see two, vertigo, you have dizziness, ataxia, meaning that there'll be loss of balance. Dysarthria means that your speech becomes a little bit some way, you can't really articulate your speech. Tetraparesis means that you are going to have weakness in all four limbs, and then bilateral visual loss. So these are some of the clinical features you can get from a transient ischemic attack. Won't go into details there. All you should know is that once your patient comes to you with weakness, you make a diagnosis of a stroke and you request for your head CT scan. Don't be in a haste to condemn the patient, because it might just be a transient ischemic attack and the patients will have a chance of recovery in less than 24 hours. Mind you, when your head CT scan comes in transient ischemic attacks, usually you don't find anything at all. Then there's also cerebral infarction, and we tend to see this like often in our clinical practice, where the blood vessels supplying various aspects of the brain becomes blocked. So in this case, we have thromboembolic events, meaning that you have a blood clot or a thrombus there, or maybe you have an embolus, meaning blood clots moving from one side to cerebral vessels, blocks it, and then it leads to an infarction. Okay, so usually the nature of the stroke will be dependent on the severity of the infarction, and then also the site of the infarction. As I told you, if you have an infarction in the brain stem, clinical features will be different from an infarction in the cerebrum or probably the frontal lobe. Okay, so usually once the vessel occlusion will cause brain ischemia, and then this will be followed by an infarction. And once this happens, once you have an infarction, another area which is called the ischemic penumbra would form around the area of infarction. And this ischemic penumbra is capable of regaining function after recovery if you manage it well. So it tells you that once the aspect of the brain becomes infected, you don't gain function in that aspect anymore. Even when you recover, that aspect of the brain is gone. Okay. So you just have to hope that the infected area is rather small and the ischemic penumbra, which is, let's say, the side effect of inflammation, is high, so that once that one is managed properly, it will resolve, and then you have a very, very small infected area. Okay. So the patients would usually have what we call contralateral hemiplegia or hemiparesis with facial weakness. What does this mean? It means that if you see the patient and the patient has weakness, whether partial weakness or total weakness on the left-hand side, it means the stroke is in the right aspect or the right hemisphere of the brain. If the patient has this weakness or paralysis on the left hand, the right-hand side, then it means that the stroke is on the opposite aspect of the brain. That is what a contralateral hemiplegia or hemiparesis means. So it means right-sided weakness or right-sided paralysis. When you take your head CT scan, you would see the problem in the left hemisphere, okay? And then left-sided weakness or left-sided paralysis, when you take the CT scan, you see the problem in the right hemisphere. That is what a contralateral hemiplegia or hemiparesis means. Okay, so in strokes, that is it. Can anyone tell me the reason why this is so for Momo of 100 Ghana cedis? You guys should make me happy this evening.
Sir.
Yes.
So I think the anatomy is said that there's cross.
iPhone, what is your name, please?
Sir Foster.
All right, okay, what's that?
Yes, sir. I will not go through into details with the anatomy, but it's said that it is sort of at the brain area. It is sort of crossed.
Okay.
The verses, yes, the verses are crossed.
Okay.
Said that the feeding, that is why it makes left hand side goes to the right and right also go to the left. Okay,
that's a good effort. But when you say vessels, specifically, what vessels are you talking about?
Okay, it's those feeding the, how do you call it? Is it the blood vessels feeding for that side?
You came close. Yeah. Well done. You've made the work easy for someone else. You made it easy for someone. Anybody wants to try? So have you heard of the principle of decassation before? You've heard the word decassate before, yes, right? Yes, sir. Great, yes, great. So that is it. So you got it right, but then I was expecting you to say the nerve tract, not the word, the nerve tracts, not the blood vessels. So it's rather the neuronal tract. So what happens is that there's a cross, right? So once it's coming from the brain to supply the lower aspect of the body, it crosses, or the term is it decassates. So the right fibers would decassate to the left. The left fibers would decassate to the right. Okay, and then it comes down. So then if you have a patient who has a left-sided weakness, in actual fact, the damage is in the right hemisphere. Okay, because of that principle of decassation. So let's see if we can see an image of that. Okay. Okay, great. So you can see my new new slide, right? Or you can't see it?
No, sir.
Okay, wait. All right. I'm sure you can see it now.
Yes, sir.
Excellent. So this is, let's look at this image. This one explains it better. So this is what we're trying to talk about. So you can see that this is a brain here. So this will be your right hemisphere. This will be the left hemisphere. Okay. And then you can see the spinal cord down here. This whole thing is the brain stem here. Okay. So usually the fibers, let's say fibers are rising from the left side. As you can see, these fibers are coming from the left side. They come all the way, and then you can see this is a central point. What do? They cross the middle and they come to the right-hand side. You get it? And then you have the same thing happening here. Comes all the way and it crosses. So that's one picture. There's also another picture that you can see here. Fibers come and they cross. Fibers come and they cross. Okay. This is what we call decassation. Let's look at the last picture. So you can see here clearly how beautiful it is. Comes down here and then it crosses to the side. Then there's this which comes here and then it crosses. So then it tells you if a patient has weakness here, in actual fact, the problem is where? Here. If a patient has weakness here, in actual fact, the problem is here. Okay, so when you go for your clinicals, you try as much as possible to look out for those ones.
Thank you.
You're welcome. So basically, and that is it when you're looking at cerebral infarction. And of course, if the dominant hemisphere is involved, your patient will be able to talk. And so in most of us, most people who end up having stroke, and then the problem will be in the left side of the brain, will be unable to talk, because most people are right-handed. So the dominant hemisphere is what's the left side of the brain. And for people who are southpaws or left-handed, the dominant hemisphere would be what's the right side of the brain. So if you have a stroke, you are right-handed and the stroke is in the left aspect of the brain, you are going to have issues on your right-hand side, and it's also going to affect your speech. Okay, so if a left-handed person should get a stroke in the right side of the brain, the right side of the brain is the dominant hemisphere for the left-handed person. So this person is going to have aphasia, or they cannot talk. Okay. So initially, when you try to check the reflexes, I think I organized a class on clinical method for central nervous system, or the nervous system itself, and we did Babinski sign in class. I'm sure the others too know what Babinski is. Otherwise, you can just look at a YouTube video on Babinski reflex or Babinski sign or extensor plantar reflex. So once you try, and then you use something with a little bit of a sharp edge under the feet or the sole of the foot of the patient, going from the great toe towards the small toe, and then all the way down to where the heel is. Ideally, when you do that, okay, and then the patient lifts up all the toe, it goes up, then we say that you've achieved what we call an extensor plantar reflex. And this would usually mean that the problem you have is what's an upper motor neuron lesion. Strokes are upper motor neuron lesions, okay? Upper motor neuron lesion means that the damage, or wherever the problem is above the nucleus of the nerve. So when you take a look at you go back to your anatomy, your central nervous system and whatnot, your cranial nerves and all that, they have nucleus, okay? In plural, I say they all have, there's a nucleus or the nuclei. And so you have nerves that come towards the nuclei, and you have nerves that move away from the nuclei, okay? So if you test, and then basically whatever problem it is, you are getting the toes and then the going up, the great toe and the other toes going up, that means you have an extensor plantar reflex. It means that the great toe and the other toes have what extended. Okay, if it comes down, it means it's what it has flexed. So that's called what a flexor plantar reflex. If you should do a Babinski sign, which I expect that you all watch a video, and then the toes flex, then you have a flexor plantar reflex, then it means that the problem you have is a lower motor neuron lesion, meaning that it's below the nucleus of the nerve, okay? But then for upper motor neuron lesions like strokes, it will be what? An extensor plantar reflex. And also the reflexes will be hyper. Initially, they are areflexic, that's the initial one where the stroke is still in evolution. But once the stroke becomes established, they will have hyperreflexia. They will have an extensor plantar reflex. If you try to check for the tone, you realize that they have hypertonia. So everything with hyper and upper motor neuron lesion will sort of go up. Okay, so the other members in the class who joined the clinical, who were in the clinical method class, can share the slides on examination with your colleagues and the video so that they can all know what I'm talking about. So we looked at cerebral infarction. What if it's the brainstem that's infarcted? You have various syndromes. If it's the medulla that is infarcted, features will be different. If it's pons, you have different features. If it's the midbrain, you have different features. There are myriad of different features. You should all try as much as possible to know some of these features, and it will point you to, okay, what are we talking about? And knowing these features would mean that you should know the function of the pons, the medulla, and the midbrain. So try and look at the anatomy and also look at your physiology. One syndrome is called the lateral medullary syndrome. So if you have poor perfusion going to the lateral aspect of the medulla, you can develop a lateral medullary syndrome where you are going to have issues with pain, temperature, and then you are going to have some form of cerebellar signs. Remember, the cerebellum is responsible for maintaining balance and all that. Okay, so if you lose the function of your cerebellum, you'd have issues with maintaining that kind of balance. So you have ataxia, you show features, what we call pass pointing, and then there's the hypokinesia. Okay, your clinical methods is there. Kindly try and get the slides from your colleagues. I put everything in there. So lateral medullary syndrome for you. And the reason why you're going to have deficits with pain and temperature is that is where the fibers pass. The pain and temperature fibers will pass through the lateral aspect of the medulla. So once you have an issue there, then you are going to have a contralateral deficit. Contralateral here means that there's a decussation, like what I showed you. So you're going to have a deficit in pain and temperature. Okay. The reticular activating system, or the RAS, also finds it's found in the brain stem. So if you have damage to the reticular activating system, patient would go into coma. So when you have a patient who has a stroke and is in coma, then you know that the reticular activating system is basically involved in the stroke. You can also have what we call a locked-in syndrome. So you have a massive brain damage below cranial nerve 3. Okay, so it means that cranial nerve 3 is working fine. And if you remember, the function of cranial nerve 3, which is also known as oculomotor, is supposed to control what's the extraocular muscles. Okay, so all your inferior oblique, your medial rectus, all those things, oculomotor is supposed to be controlling that. So once the patient has issues way below all the other, the lateral rectus, which is supposed to be controlled by the abducens nerve, the superior oblique, which is to be controlled by the trochlear nerve, would all become impaired, but your cranial nerve will still be working. So patient is basically lying down there. You can move your eye, okay, but then what you are doing is you are just lying there. Your brain, the cortex is functioning, but then your hands cannot move. Your lower limbs cannot move. Okay, you can only communicate with the eyes, and all that you can do is that you can just move your eye in the vertical position. Okay, so that is what we are talking about when we say locked-in syndrome. So you are basically locked in. You can't move any part of your body except the muscles that the cranial nerve or oculomotor supplies. That is what you can move. Okay, you can also have what we call the pseudobulbar palsy, where you have issues with your tongue and then the pharyngeal muscle, so you'll be unable to swallow and whatnot. Okay, so try and go through the anatomy. It's all anatomy. Once you get your anatomy right and you get your clinical methods right, this should be easy. So how would we manage an infarction? So yeah, basically know that once a patient has a stroke, you need to involve other team members. It's not just about you. You need a physician specialist, you need a vascular specialist, you need a physiotherapist, you need like almost everybody. You need nurses that will be ready to dress bed sores and whatnot. Okay, you need a dietitian and all that. So you admit to a multidisciplinary stroke unit, you would have to try and nurse your patient nil per os in the initial stages, because mind you, your patient might be having some sort of pseudobulbar palsy, you'll be unable to swallow. You try and then you give your patient food and your patient will aspirate, and that will kill your patient. So in the initial phases, whilst you are still assessing nil per os, you assess, you manage airway, you check swallowing, you check blood pressure and whatnot. Okay. You make sure your patient doesn't develop hypoglycemia. At the same time, you make sure you are controlling blood sugar so you don't have hyperglycemia if your patient is a diabetic. Okay, look at temperature as well. Make sure your patient doesn't go too cold. Make sure your patient doesn't have increased temperature. Give oxygen in the initial phases, okay? Because what is causing the stroke is an infarction. You need to try and then saturate our patient with some oxygen. Once you've done a head CT scan and you are sure that there's no bleed, this is purely an infarction, you need to put a patient on oral aspirin or clopidogrel. Sometimes you can do a combination of aspirin and clopidogrel, okay? You can also go ahead and then you start what we call a thrombolytic therapy, where we are giving a tissue plasminogen activator just to break down the clot that has been formed, okay? So usually that's what you do for your patient. And sometimes to help improve their brain function, we put them on some medication. We put them on what we call paracetam. It's one of the medications that you can put your patient on. So you go ahead and then you put your patient on paracetam to help in basically the brain function and to help especially those who have issues with speech and all that. It plays a very, very, very key role in that. Citicoline also helps, okay? Remember we talked about the ischemic penumbra. So these medications will basically help and then it would improve the recovery of the ischemic penumbra. So we can add that to the treatment as well. You give the patient statins, okay? And you usually start this if it's an impractical ischemic stroke, because most likely whatever caused it, I mean, there might be some form of hyperlipidemia. So you put the patient on statins. In all this, you are managing your blood pressure well. The patient is diabetic, you are managing that well as well, okay? There's also role for surgery where you can do an endarterectomy, meaning that you can go into the blood vessel and then remove the blood, the thrombus or whatever plug that is stuck in there, okay? You can remove it. And then there's also a role for percutaneous transluminal angioplasty, where you basically try and then you stent your blood vessel. Okay, so that's for infarction. The opposite is hemorrhage, where basically the blood vessel ruptures. So blood vessels supplying the cerebrum, the aspect of the brain that I showed you, the largest aspects of the brain can rupture, okay? So once it ruptures, you can have issues. You can have blood vessels supplying the cerebellum also rupturing. This is called intracerebellar hemorrhage, okay? So as you can see, you can have an intracerebral hemorrhage and intracerebellar hemorrhage. Presentations will be different because cerebrum and then the cerebellum, they do different things, okay? So you should know what they do. Clearly, we are saying the cerebellum is for balance and whatnot. So if you have problems there, you would see the clear ataxia, there's nystagmus, stupor, patients go into coma. When you have intracerebral hemorrhage, you'd also see that kind of features when it comes to the hemiplegia, hemiparesis, and all that. Okay. So how would you manage? You need to confirm. So doing the CT scan is very essential because that would basically change your management. It will tell you to do, give something for against blood clots, or it will tell you that, hey, patient is bleeding, so don't go and start antiplatelets or whatnot, okay? So once you confirm with the CT scan and then you know this is a hemorrhage, you need to avoid the antiplatelets, thrombolytics and whatnot. You need to control your blood pressure, but you don't want to drop it down too drastic because you might be having a hemorrhage. If you go ahead and drop the pressures down too drastic, it would also lead to an infarction, okay? So you don't drop it down too drastic, and then you quickly inform the neurological and the neurosurgical team. The neurosurgical team can work and then evacuate the blood clot where necessary. You can also have what we call a subarachnoid hemorrhage, which we usually talk about. And when you have aneurysm, you know what an aneurysm is. You have a blood vessel, but then there's an abnormal dilatation of the blood vessels. for those of us who don't know what aneurysm, let's see if we can show a picture of that. Great. So let's see. Can you see my screen now?
Yes, sir.
Great. Okay. So you see there's like a blood vessel here, and there's like an abnormal dilatation of the blood vessel. It's not supposed to be there. Once it dilates, it tells you that, okay, this side of the blood vessel, the wall is not strong enough. So you have like a bulge over there. This can rupture anytime, as you can see if you follow where the cursor is. So this is what we call an aneurysm. You can have an aneurysm sitting in the brain, okay? So sometimes you hear people saying, oh, bury aneurysm, what's not. You can have aneurysm sitting there, and then this can actually rupture. So you have something like this, it ruptures, and then you bleed in your subarachnoid space, and that is what we call a subarachnoid hemorrhage. Okay, remember the brain has a dura mater, pia mater, and arachnoid mater. Remember those layers in the brain. So okay, so once you have a subarachnoid hemorrhage, which could be due to a rupture of an aneurysm, or maybe you have blood vessels that have been formed, what we call arteriovenous malformation, or the patient has a bleeding disorder or has a collagen disease. You need collagen to make fibers stronger. So Ehlers-Danlos syndrome, Marfan syndrome, these people have issues with collagen. And so there's some sort of extensibility, and it can rupture easily. Okay, so once you have that, your patients will bleed. And if you are bleeding in the subarachnoid space, you have severe headaches. But when a patient comes to you and you check and blood pressures are high, the patient tells you that, doc, this is the most severe form of headache I've ever had in my life. You need to suspect a subarachnoid hemorrhage, okay? Whenever you have a patient who comes with that, suspect a subarachnoid hemorrhage. And because they are bleeding into the subarachnoid space, as you know, they can have signs of meningism, so they can have stiff necks and all that. They'll be vomiting, can go into coma, and you can lose the patient. Once they come, you need to bed rest patients, you control blood pressures nicely. I mean, we give Dexa 4 milligrams 6 hourly, even though it's controversial in some cases, but we still give it. The antihypertensive of choice in subarachnoid hemorrhage is nimodipine. This question would usually pops up in your exams. Once you're talking about subarachnoid hemorrhage, we'll ask you, what is the antihypertensive of choice? It's nimodipine. Okay, so you give nimodipine 60 milligrams 4 to 6 hourly for 21 days, and then once you give, you try and taper down the dose. So basically, you need to start within 4 days of your hemorrhage, otherwise it might not be so effective. Okay, if intracranial pressure is high, you need to give your patient IV mannitol. You could also have subdural hemorrhage, where you have the patients basically bleeding in the subdural space. Okay, and this would usually take weeks because the subdural space is relatively, wider as compared to the extradural space. So patients will have headaches, confusion, seizures if the bleed is so massive, but it will take weeks to months for symptoms to appear. Okay, then you can have extradural hemorrhage. Okay, and this one, because the space for the hemorrhage to collect is not so large, effects are faster. So patients, once you have the damage, the patient would have some form of unconsciousness, a brief episode of unconsciousness, and the patient will come back. So this moment where the patient comes back is called a lucid interval. So if you have any question and then they ask you about lucid interval, they are talking about extradural hemorrhage. Okay, so the lucid interval, the patient looks fine and all that, and then all of a sudden, within a twinkle of an eye, the patient will start deteriorating, the pupils will start dilating, patients will start having some form of hemiparesis. Okay, and most of the time is due to injury of the middle meningeal artery. The middle meningeal artery is found in an area which is, easier for it to get damaged. Okay, so let's look at what the middle meningeal artery is, where it is. So if you can see my screen now, you can see, can you see my screen?
Yes, sir.
Yes, sir.
Great. So that point where the circle is called the pterion. In this pterion, you can see that you have a lot of bones coming together, sutures coming together. As you can see, the frontal suture is somewhere here, parietal suture is somewhere here. Okay, you have temporal suture and also coming in there. So this area, and the sutures have sharp edges. So if anything hits this area and it breaks, it will cut through the blood vessel. And then, as you can see, the middle meningeal artery comes here and there's a branch. It cuts through the blood vessel and you end up bleeding severely. Okay, so if you should hit your head, make sure you don't hit your head at the area of the pterion, because if you do, the bleed is that massive because of the damage to the middle meningeal artery. Okay.
Where? Echo. Ellie.
Where?
Mabel.
Okay, so we've seen where the middle meningeal artery basically is. Okay. So of course, symptoms would develop, and then because of the collection of blood, eventually you end up having some form of total weakness in all four limbs and respiratory arrest, because there's a lot of blood collection. It causes you to cone, meaning it causes the brain stem to move out of the foramen magnum of the skull. So it cones, and once it cones, you are going to have these issues. Management for that, we need to call the neurosurgeons to come in after you've done your CT scan and your MRI. So stroke is quite a big topic. This is even a simplified form so that you can appreciate and understand and apply what you learned. Let's take questions in 2 minutes. I think we have 15 minutes. We'll touch on Guillain-Barré. So if you have any questions at all, let's quickly take it and then we can go on.
Hello, sir.
Yes, please.
Yeah, you talk about the contralateral this hemiplasia. Can we have it? Can we have the epilateral ones?
Yes, you can have ipsilateral, but that is not classic of a stroke. Do you get it? So if you have a damage to any aspect of the central nervous system, which is below how do you call it, the decussation, okay, then you would have some form of ipsilateral paralysis. Okay. Yes, you're welcome. So you try and read on it. Basically, if you have like damages below that aspect of the decussation, and so if maybe you have if you look at the decussation, it comes all the way. The medulla is like the medulla. You know how the brainstem looks like. You have the midbrain, you have pons, and medulla is down there. If problem is in the medulla, usually you tend to have some form of ipsilateral hemiparesis or hemiplegia. Okay, so you just look at the anatomy and then we try and play around. You look at the parts where the decussation is. Every part below will give you ipsilateral issues.
Okay, so I have a question.
Yes, please.
I want to ask if Glasgow Coma Score has a role to play in the management of strokes.
Yes, of course. Glasgow Coma Score has a role to play. I was expecting that you would have done that during your clinical methods. So you should all take a look at the Glasgow Coma Score, because your examination is not complete if you fail to tell us the GCS of the patient. You need to take a look at it. So you should all look at Glasgow Coma Score, the eye, vocal movements, just look at it and then know what it entails. Know the 6 parameters when you're looking at motor, the 5 parameters when you're looking at verbal, the 4 parameters when you're looking at eye movement. Know what it entails, and then know what you will consider as severe in terms of head injury. Know what you consider as severe head injury or brain injury, moderate or mild. Okay.
Okay. And the last question.
Yes.
What
Please.
accounts for the prognosis that some survive, some do not?
Okay, so it depends on the extent of the injury. That is one. And also two, it depends on how fast you get to a caregiving site. That is two. Okay. Because of course, and it depends on the type of stroke you have, really. Most people do better with ischemic stroke than hemorrhagic stroke. If it's a bleed, the prognosis is usually not so good. Okay, that is one. If it's a bleed and it's massive, then your prognosis is that bad. If it's a massive bleed and then you get to the caregiving side a little bit late, or even you get to the caregiving side early and your CT scan is late, and so we don't know if it's a massive bleed or not. By the time we call the neurosurgeons, you are gone. So, I mean, all these factors come in play, but basically it's just the extent of the damage and the type of damage you have.
Okay, thank you.
You're welcome. So kindly try as much as possible to read through stroke. I didn't want to rush through so that you get the concept, because you'll be seeing a lot of strokes in your practice. Okay, so try as much as possible and then you take a look at them. So let's talk about Guillain-Barré. Did any of you read about Guillain-Barré? Some few slides, we should be done in a bit. Okay, so they are looking at the nervous system, okay, and then we are looking at basically paralysis. Okay, so we'll talk about Guillain-Barré, and it's one of the conditions that you can find when you go to your internal medicine wards. Okay, you have a patient who would present, maybe a young man present to you with some form of weakness, and they'll tell you that they started feeling weak in the lower aspect of the body, and gradually they feel the weakness is climbing up. They come to you. Sometimes the weakness is associated with severe pain as well. Okay. even before that, they will just give you a brief history. Oh, I was running some time back, or had a cold or something. When it resolved, I started experiencing this sort of weakness and associated pain. Okay. Then as a clinician, it points you to that direction that, all right, okay, hold up, this could actually be a case of Guillain-Barré. It's not so common, okay? But with the advent of COVID, and as we are talking about infections being triggers, COVID is basically doing everything now. Right? It's like on top of its game. So there are also cases of Guillain-Barré associated with COVID. Okay. So something short, I just wanted you guys to know that there's a condition of that sort, so that when you hear it on the wards, you won't feel out of place. So what is Guillain-Barré? And once we are talking about Guillain-Barré, we say that it's a clinical syndrome. Okay, so it means it's a constellation of signs and symptoms, and it would present to what we call a polyradiculoneuropathy. Okay, so what does a radiculoneuropathy mean? A radiculoneuropathy means that you have issues of an inflammation of the nerve all the way from the nerve roots, as where the nerve is arising from, okay, and it's involving all the nerve. So that's a radiculoneuropathy. Okay, you probably have just a neuropathy. It's possible that it's just involving some parts of, but a radiculoneuropathy will tell you that the inflammation is starting from the nerve root and it's sort of spreading to the other aspects. Poly means that it's not just one, so you have multiple nerves involved. Okay, so that is what we are looking at. So once you say polyradiculopathy, and that's what we mean. Let's see if we can see an image of that. Not really finding any classic images that will make it easier. Just a little bit. All right, let's see if this will do. Can you see my screen, please? Can you see my screen?
Yes, sir.
All right, great.
Yes, sir.
So if you look at this is a cervical vertebra here. The nerves would often arise from the spinal cord, which will be in the vertebra. Okay, it's not so clear, but bear with me. So the inflammation is not just here. You have the inflammation arising all the way from the spinal cord, which is inside here, okay, coming down. Okay, so inflammation, it would involve the nerve roots, not just, all right, I think this is good. Right, so you can see, okay, so this nerve root here, inflammation would involve all the way down. Okay, so that is basically what we are talking about. So once we talk about Guillain-Barré, you should know that we are talking about a polyradiculopathy. Okay, and this polyradiculopathy is basically due to destruction of the myelin sheath. As you know, the myelin sheath is what covers the nerve nicely. Okay, so if the myelin sheath becomes destroyed, then it means that messages that will be transmitted via the nerve will be impaired. We all know what the myelin sheath is. Okay. Do you have anyone here who doesn't know what the myelin sheath is? So once you have that kind of demyelination, then you are going to have issues with impulse transmission. Okay, and basically, in Guillain-Barré, basically that is what we are talking about. Okay, so you can see from this image that I'm sharing here, this is like a nerve, right? Where you have the axon, the cell body and whatnot. And then you can see around it is a myelin sheath, which allows for impulse transmission. And when we talk about demyelination, basically we say that this myelin sheath, which is supposed to protect the nerve and improve the pace of impulse transmission, becomes destroyed. Okay, so that's what happens in Guillain-Barré. You have destruction of the myelin sheath. So this is a normal myelin sheath. This is a demyelinated nerve. Okay, so you have that in Guillain-Barré, and we'll know why that is the case in a bit. So this is actually an acute condition. So the other name as we go on, we say it's called an acute inflammatory demyelinating polyradicular neuropathy. It's long, but then it's easier to remember. One, if you know this, then you know what the condition is. You know it's a polyradicular neuropathy, meaning that it's a neuropathy which involves the nerve roots itself, multiple nerves, that's one. And the main cause is demyelination, and it's an acute condition. Okay, so as you know, that is what it means. And what we are saying is that looking at Guillain-Barré syndrome, it is monophasic. It means when you get it once, you don't get it again. It is not recurrent like other conditions where you have polyphasic. No, Guillain-Barré is monophasic. Okay. And they would present with muscle weakness and diminished reflexes. And you know that the nerve is responsible for muscle strength and reflexes. So once it becomes demyelinated, then you're going to have weakness and then diminished reflexes. Another name is post-infective neuropathy, and that points us to our etiopathogenesis. So basically, for you to develop Guillain-Barré syndrome, most patients would have a prior infection, maybe a gastrointestinal infection or respiratory tract infection. Okay, so organisms that have been, culprits for Guillain-Barré, you have Campylobacter jejuni, we know it causes GI infections, you have cytomegalovirus infection. People would tend to have this, and once they have these, okay, what happens is that this infection, these organisms would produce antigens. Your body would respond to these antigens by making antibodies, okay? But the thing is that the antigens that these organisms are producing, okay, they look similar to some of the antigens in the myelin sheath. So the scientific term is called molecular mimicry. So these organisms, usually when they come into your system, they have a liposaccharide, they are covered by a liposaccharide. This liposaccharide antigen would basically try to mimic you, the human being in your system, so that you can make antibodies towards it. But of course, your human body would make antibodies towards this foreign substance, this antigen, because it's an infection. And once it makes the antibody, it goes to destroy the infection. But afterwards, it fails to recognize your normal, thing that looks like the liposaccharide. Okay, so your antibodies will cross-react with components of your myelin sheath The myelin sheath contains gangliosides, glycolipids, which looks like the lipoprotein. So they look alike, they mimic. Okay, so the organism will basically try to mimic what you have. And so once you make antibodies against the organism, the antibody would fail to recognize you and will start attacking you, and then it will destroy the cell. So it looks like some form of autoimmune condition. Okay, and the principle is called molecular mimicry. Okay, so this will lead to peripheral nerve damage. So basically that's it. So once you have that demyelination, then you are going to have issues, you're going to have weakness, and usually the weakness will be in an ascending fashion. That is the classic aspect of it. It starts from below and then it affects the upper aspect, and eventually it would affect the trunk. And you know the trunk has a respiratory muscles, and that is the danger. Once it affects it, then it means the patient will go into respiratory distress and you can lose your patient. Okay. The reason why you need to know about Guillain-Barré, because of the risk of respiratory distress and respiratory failure. So, I mean, the lab people here, if you want to go into detail, pathologically, you have lymphocytic infiltration of the spinal root and then the peripheral nerves, and then you also have macrophage mediated stripping of the myelin. So it's basically an inflammatory process. Okay. So as you can see, once the myelin sheath is damaged, as I said, there will be defective propagation of nerve impulses. Okay, so it's easy to understand. And eventually this will lead to paralysis. The difference between this form of paralysis and the paralysis of a stroke is that the stroke will give you a spastic paralysis. As I said, if someone gets a stroke and becomes paralyzed, in the initial phase, the tone will be decreased, but as the stroke stays for long, the tone increases. And that's why when in stroke patients, when you try to read them or try to check for tone, you realize they have hypertonia. The type of paralysis you have in stroke and other upper motor neuron lesion is a spastic paralysis, but in lower motor neuron lesion, all right, so clinical features, you've already talked about that. So once nerves become involved, you have numbness, you have paresthesias and whatnot. Okay, then there's also the weakness, which we talked about, and would eventually involve, it would eventually involve the respiratory system. Okay. The thing about it is the progression is in ascending order and it's symmetrical. So if left, then right will also be affected at the same time. It's not like you have left-sided weakness, then right. No, all will be affected at the same time. So it's symmetrical. Cranial nerve can become involved, and once cranial nerves become involved, you have issues with your cranial nerve. So your facial nerve wouldn't work well. So your face will droop. You have diplopia. You have dysarthria. So all of these are functions of cranial nerves. Okay. So once you have issues with the cranial nerves, then you're going to have these features. Autonomic nervous system would also become impaired. So your pulse can either go so fast or too low. Okay, you are going to have issues with blood pressure control. You are going to be sweating anyhow, or you won't even sweat at all. You're going to have constipation, or you are going to have the opposite, okay, or urine retention. So these are some of the features, and these are all features that are supplied by nerves, okay, either peripheral nerves or central and cranial nerves or the autonomic nervous system. So the disease would usually get worse from day 12 to day 28, and then it will plateau, and then recovery will begin 2 to 4 weeks after. Okay. differential diagnosis, you have a host of things that can also mimic Guillain-Barré, like transverse myelitis, cord compression. All of these things will cause paralysis, poliomyelitis, HIV, peripheral neuropathy, vitamin B deficiency, stroke if it's bilateral, or conversion disorder. In this case, there's actually no problem, but then it's more of a conversion disorders are psychiatric problems. So the patient doesn't really have paralysis, but then the patient feels they have paralysis. Okay. And most of the time, they tend to do it for attention seeking. Okay, it's called conversion disorder. They elicit other symptoms as well. It's a very interesting thing, so you should read about it. Investigations, you can do an electromyography or nerve conduction studies, lung function tests because of how important the respiratory system is to us. We look for autoantibodies because of what we just talked about, the fact that the body would make antibodies towards it. CSF analysis, usually when you look at a CSF fluid, there's elevated protein level and white blood cell because of the infection. Full blood count, inflammatory markers, and look for the organism. So you can do a COVID screen, you can do a Campylobacter jejuni screen through a stool culture, you can do a retro screen, check your electrolytes, because if you have electrolytes imbalance, that will also affect your muscles and whatnot. So host of investigation. Of course, CT scan, MRI to rule out a stroke. Management, you need to admit your patient. Basically, your management is supportive in Guillain-Barré. You need to keep your patient alive until spontaneous recovery, just like what we said in acute kidney injury. So once your patient's on admission, you need to prevent things like DVT and PE. So you have to give them anticoagulation, which we've been talking about. So your heparin is very, very essential. You need to manage pain, because I said it comes with lots of pain. So analgesia, your NSAIDs because of inflammation. If you need to give opioids, you need to be careful because of the risk of respiratory depression in this patient. Okay. Then chest physiotherapy, because they will just be in bed so that you prevent infections. Rehabilitation is very necessary. Once they are in bed, you need to do your physiotherapy to maintain the muscle bulk and all that. No proven treatment as of yet, but then we know that once you give them intravenous immunoglobulins, it helps. Sometimes you can do what we call a plasmapheresis. It also helps. Okay, it's sort of filtering the plasma. It also helps. So basically, this is Guillain-Barré. I think our time is fast spent, so I'll take questions and then we can plan for a lecture on possibly tomorrow or Friday. Any questions, please?
Hello, sir.
It's quite straightforward. Yes, hi.
Yeah, please. You said with a stroke, you said that when the neuron gets damaged, it's hardly before the person can get function. But there's also this idea of neuroplasticity. The fact that the brain, neuroplasticity, the fact that the brain is a plastic.
Okay. Yeah.
And the fact that the brain is a plastic, and any environmental input, any things you can rewire that part, other part to take that function.
Okay.
After post this stroke rehabilitation.
Yeah.
So I'm just tipping about how it can also gain other functions with neuroplasticity.
Yes. Yes. That's great. So yeah, so there's also that feature, and that would basically not be the aspect that is damaged, because the aspect that is damaged is gone. But then through the physio and then medications, as I said, the citicoline and your paracetams and what else, the other aspect that you would be improving, as you said, can also help take up functions. But sometimes, of course, it depends. If you have the damage in the frontal aspect, right? And then you have the stroke and the damage is there. Because of the function is supposed to play, if the damage is not so extensive, then it means that with time, you can recover and still remember some stuff. Okay. But of course, if there's a massive hemorrhage and then it's affecting maybe a different lobe at all, it will be interesting to let's say, the function of the temporal lobe and there's a massive hemorrhage affecting the temporal lobe. It will be quite interesting trying to see if the frontal lobe can take up the function of the temporal lobe. So even though you can have that principle in terms of plasticity, it also depends on the site. You can't just develop that function across board, but it's an interesting one.
Thank you.
You're welcome. So kindly go through the slides. The next time we meet, we'll talk about HIV/AIDS. Did I give leukemias to any of the groups to present on? I think I did, right?
No.
Oh, I didn't.
No.
No group is presenting on leukemias.
No, malaria, STI.
Okay.
Gastroenteritis, anemia, epilepsy, and vascular disorder.
Okay, great. All right, okay, no problem. So I would have to take you on leukemias too, because there are things that you would see. Okay. Or you want me to let you go and read on your own? Don't worry, no, I'll take you. Who said no? So I'll give you a lecture. I'll give you a lecture on leukemia. I'll give you a lecture on multiple sclerosis, and I'll give you a lecture on HIV. These 3 lectures, but technically we have only Friday, which would make it impossible. So you discuss if it would be possible to have a 1 hour tomorrow. We can chip in leukemias and the we can chip in leukemias and multiple sclerosis and do HIV on Friday. The other option.
We are now working on your presentation.
The other option is that the other option is that we will have to, because even with emergency medicine, I'm sure Nick will have a discussion with you on how we can have 1 hour lecture every day from next week. So the other option is that we can put that 1 hour to Monday after your online lecture. I know you'll be tired, but just 8 to 9,
yes, we
can have a lecture. So then, yes, please.
Are we going to write exams on the emergency as well?
Yes, you write exams. You will write exams. I mean, as I always say, I am malleable, so it depends on what you want to do. If you don't write an exam, a different lecturer would set exams for you after I've taught you. If you write the exams, means I'm setting the question for you and I'll mark for you to get your papers in less than 3 days of the exams. So you have to make a decision. As it stands now, your internal medicine exam will be on the Friday, 27th of August. And then, and will be on the 27th of August. Technically, we are finishing on Monday. Technically, we are finishing internal medicine 2 on Monday, which is that 1 hour. We're supposed to finish this weekend, which is Sunday, but we'll finish on Monday. So you have the whole of 16th to 22nd, which is 1 week, and then 23rd to 27th, which is almost another week to prepare. Even though you'll be having 1 hour lectures, don't worry, I'll be nice, so you do well. I'll be nice, so you do well. So exams, I promise I'll be nice. I know you've been under intense pressure, and we are not in normal times. So don't worry, I'll be nice. So your emergency medicine, ideally, we're supposed to do 5 questions, session B, but because your seniors just did 5 questions on Friday, but because I'll be nice, you only do 3 questions with sort of close to the same number of hours. Your emergency medicine, we would have that on Friday. I would have been happier if we could have it the week after your internal medicine, but I'm sure it will be difficult for you. So we'll have that on Friday, 10 September. We need to have it on 10 September. Once we lose that time frame, we can't have it again.
All right.
Okay, so we'll have it on Friday, 10th of September, and you have your results on Monday, 13th of September. So then I'll be down with you and you have all the time to do all other things. Take your time for internal medicine if you want. We'll arrange that time, and that is when you can come to University of Ghana Medical Center, the simulation center, to be trained by the other specialists there. We'll work that one out after your exams. So just prepare for Friday, 27. There are some candidates who will need to reset my paper, as I said, and there are 2 candidates who were unable to write at all. They would have their exams in between. The exams will be writing on the 27th and on the 10th. So they will write their exams on the 3rd of September. So they are going to have 3 exams. So they will have one on the 27th, one on the 3rd, and then another one on the 10th. Okay, so they should prepare. So between 27th and 10th, there's an emergency medicine one supplementary, okay, which will be the 3rd of September. I think, yes, I think that will be it. I've done well, right?
That's it. So you have done well.
So you'll be fine. Don't worry. Just put in the effort. I don't want anyone to have to rewrite emergency medicine 2 or internal medicine 1 because I'll be unable to conduct that exams for you. Okay, so all the best, and we'll meet on Friday and discuss HIV. Good night.
All right. Good night, sir.
Yeah.
All right. Good night.